Good evening, and a lot of attendees are already here. Let us begin the session with your permission.
Hello, parents. Wishing you all a very happy Dasera. We are in the month of October, and October is marked globally to spread the awareness of ADHD, Attention Deficit Hyperactivity Disorder. As parents, are we giving enough attention to the inattention of our children? Being distracted is not the same as being inattentive, but inattention could be a result of distraction. This distraction could be either due to internal thoughts or external stimuli, sleep deprivation, hunger, family discord, bullying, and anxiety, along with ADHD, which by far remain the most common brain-based condition of early childhood that affects a child's ability to stay focused and pay attention throughout the day. An inattentive child may consistently drop in his school grades but excel in extracurricular activities or even video games. As frustrating it might be for both the parents and teachers alike, it is required to focus on the consequence for the behavior issues and address the root cause. Attention issues in the classroom can negatively affect a child's ability to comprehend and process academic material, make new friends, or even maintain friendships, making it difficult to thrive in the classroom setting. Although ADHD might be one potential cause of inattention, but anxiety, depression, low self-esteem, family problems, grief, social issues, and learning differences can all result in inattention. Making time to connect with your child makes a huge difference in their life. Listening is the key. We parents have the habit to talk more than we listen. Kids open up about their problems when they know their parents are present, listening, and available. It's important to set and maintain healthy limits and establishing healthy sleep hygiene. Consistent sleep makes a huge difference in the life of an inattentive child. Children are not skilled at filtering out distractions as adults are, and this is even more difficult for an inattentive child. In these modern times, parents often check social media with one hand while listening to the news and ask a child about his day. Unfortunately, this practice sets kids up for a distracted living. Make single tasking, doing one thing at a time, teaches a kid to rule out extraneous stimuli. Inattentive children can be difficult to deal with. They struggle to follow directions. Often they don't finish what they start. Might need constant reminders, but they do things this way because this is how their brain works. Yelling and harsh consequences don't help. Teach kids to pay attention. In fact, they are more likely to trigger anxiety, and anxiety leads more to inattention. Focusing on positive parenting and connecting with your child is the key to skillfully deal with a problem. Remain calm and providing guidance. We send a clear message to our children that we are there for them. And as they say, as your child is figuring out the world around them, you are going to be figuring out how to best parent to them. Be their world and provide them with love, confidence, and emotional security.
So, a very good evening to all the attendees today. We are lucky and we are honored to have Dr. Archana Kadam today. My name is Diptiman Tripathi. I'm the Managing Director of WEFA in India. Attention to Emotion is an initiative by I'm the Best Mom. And since we are in the month of October and we are discussing, we are spreading the awareness of the mental health well-being ADHD, the whole month, dyslexia. And here today we are going to have a discussion and we are going to learn a lot from Dr. Archana about attention to inattention. Ma'am is a MD DNP Pediatrics from BJ Medical College and KEM Hospital in Pune, practicing developmental and behavioral pediatrics in Pune since 2004 as a consultant developmental pediatrician at KEM Hospital and Jahangir Hospital, Pune. Ma'am, it's an honor to have you today.
Thank you so much, sir. Uh, I'll just share my screen.
Yes, please. And with this, I may request all the attendees, they might be having a lot of questions. They can use the Q&A panel where they can submit the question, and we will try to take all the questions soon after the session.
Okay. Good evening, sir. Thank you for your kind introduction. And I loved that video because it was a good starting platform for us to discuss our topic today, which is hyperactivity and inattention. And we are going to see whether it is ADHD. Now, we all know that ADHD is a neurobehavioral disorder, one of the ones that is most extensively studied. Basically, what we are dealing with is impulsivity, where the child engages into thoughtless, premature actions, hyperactivity, where the child is fidgety or restless, and inattention, where the child has difficulty focusing on tasks that need sustained attention. It's important to know that these findings need to be present in more than one setting. So, a lot of times, parents come up to us and say, "Oh, my child is 3, but he just doesn't sit down for a task and he's hyperactive." But if this child is playing with kids, all right, if he's in another setting where he's okay, probably going to a play school and learning there, it would probably be the handling at home or the stimulation at home which we would want to work on. So we need to assess the child's attention in more than one setting. Hyperactivity or ADHD can span the entire lifespan, and because children are going to school earlier, we are picking up children with attention issues really early. Now, the objective of my talk is to have a clinical approach to the diagnosis of ADHD, to just touch upon some investigations, and primarily for parents to know when attention is an issue and when it is a normal variant, and where we can work on structure and weight. Now, what I'm going to do is have two cases so that it helps us understand the concept better. This is a 4-year-old boy who was referred from his school. The basic concern in school was that he was not sitting down for tasks. The teachers felt that he was bright because he was orally, if you asked him a question, he always had the answer. But sitting down for group activities, pre-writing activities like coloring was an issue. He was on the go, moving around, and he was impulsive. He would have behavior issues, would hit kids and push kids. So there was individual supervision needed for him in class. The parents reported that there were some tantrums at home also. So when a child comes in, we start thinking as doctors, what could it be? So we probe into the history, and we found out that in the birth history, there was nothing significant, good birth weight, no major events at the time of birth. Family history was fine. There was no family history of psychiatric disorders. Then we delve into the developmental history. So we found that this boy had achieved his milestones of walking early. Now, when we assess development, we say motor skills, which is gross motor, how the child learns to sit, walk, run. Fine motor, how the child uses his hands. It is to eat, to dress, uh, to do his activities by himself, and later to draw and write. ADL is activities of daily living. Communication is how the child understands language and uses it, and behavior. So if we looked at his developmental history, we found that gross motor was fast. He started walking early. Fine motor, this child at 4 years was using both his hands for activities. Generally, handedness gets established around 3 or 4. So here there were issues where he would eat with both his hands, or he would switch his crayon when he'd do activities. As far as self skills, he was fussy about foods, was fussy with the textures of food. He was able to remove his pants but not wear them. As in terms of communication, he had started using words after 2 years, which is slightly late, and currently was communicating his needs in sentences. But when the parents asked him what he did in school, he was not able to narrate what was happening. And as we reported, the tantrums, there were some behavior issues and a little bit of aggression in school. So then we did an assessment, and then we started thinking, what could it be? Obviously, one, it could be ADHD, it could be an attention issue. Two, it could be autism spectrum, because this child has social communication issues, some sensory issues as far as textures of food. uh, Three, it could be an expressive language delay. This could be a child whose language abilities were less. This, we'd have to check the child's vision. We need to check the child's hearing. It could be a child who has global developmental delay. It could be a combination of all these factors. And in addition, it could be some environmental factors that we would need to look in. So let's look at all our differentials. We are going to rule out all these conditions in this boy. Sensory processing difficulties, which I'll talk about later, can happen in children with attention issues as well as children on the spectrum. Now, let's see case number 2. This is a bigger girl, an 8-year-old girl who's in class 3, and she was reported by the parents saying that her academic performance was okay till, say, her upper KG. And after first, her academic grades have started declining. Again, we took the history and we found that she was born premature. Her birth weight was 1.5 kgs, and she had had a neonatal ICU stay where there were no major events. Establishment of feed was an issue. Again, let's look at her development. Gross motor is okay. She loves to play outdoors. Fine motor, she is right-handed. She is independent in terms of her activities, but her fine motor in terms of buttoning, her written work is a concern. The parents say, oh, she can do everything, but she constantly needs reminders. Okay, go for a bath, go for a bath. It needs to be told to her 3 to 4 times before she actually does the task. Speech, she started normally, and the parents report that sometimes when she's in a hurry to speak, she might stammer. Behavior issues, she does tend to get angry, she forgets things. If you give her a complex instruction, she might just follow through on one or two of the complex instruction. In school, what was reported was that there was incomplete work. At times, she was daydreaming. She was good in subjects like maths, but poor in tasks that needed reading and written work. And she was great in sport. So now let's again think what it could be. One, it could be an attention issue. Two, it could be a learning difficulty. This is a child who is likely to be maybe have good intelligence but specific difficulty in learning. Three, we need to look at anxiety. A child who's having low performance and a lot of stress about it at home, that could be one reason. Four, we again need to assess the child's development, whether we are dealing with a delay. We'd also need to look at other medical conditions which may exist. Again, hearing, vision is something that we need to look into. Also, the school structure. If a child is going to a class where the class size is big, the amount of individual attention the child is getting may not be enough. So a lot of factors that we would need to look at. So now let's sort of begin on the topic. So which child with an attention issue needs an evaluation? Generally, a child between the age of 4 to 18 years who may have behavior issues like case number 1, to academic issues like case number 2, symptoms which are hampering the child's social functioning or learning, is a child who would need a detailed evaluation. There is insufficient evidence to assess children less than 4. However, with advances in diagnosis, we are able to pick up children who have attention issues earlier and start working early. As in all developmental conditions, the earlier we work, the better the outcomes we find with children. So, how do we assess a child who's brought into us, like case number one, where there are behavior issues, or case number two, where there are academic issues? Is there a blood test for ADHD? Is there an MRI test? And the answer is no. The assessment depends on a clinical interview, like we did a developmental history. Two, we assess the child's current behavior and the development when the child comes into our setting. So the parents have reported some concerns. The school has reported them. We do a developmental assessment to find out how this child is doing developmentally for his age. How is his attention? How is his self-regulation? How is his attachment with his parents? We also assess informally vision, hearing, neurological issues, and we assess the impact of the problem on the family and the child's performance in school. So, when we look at the developmental history, we find out whether there was any consumption of drugs by the mother during pregnancy, because sometimes if the mother is on drugs like anti-epileptics, attention issues may be noticed in children. Birth history, like our case number two was premature. A premature baby has a higher risk of an attention issue. Family history of attention problems. Sometimes if the child has had some infections during the neonatal period or at a later age, like meningitis or a head injury, these could hamper the child's attention. We would also look at language milestones, social milestones, look for psychosocial stressors, assess the school performance history, and take a sensory profile. Now, let's look at some red flags for language for parents. As I said, language is understanding of language, which is receptive speech, and expressive speech is how the child uses words or gestures to communicate. So, if you have a 2-year-old child who is not showing body parts, that could be a red flag. It's not a red flag for ADHD or autism, it's a red flag for language, which needs a proper evaluation. If the child is not following two-step commands like take the ball and give it to me by 3 years, it's a red flag. If the child is not using 3 words with meaning by 15 months, it's a red flag, by which we don't mean mama, baba. It's a word with meaning. Water for need is a word. If the child is not joining words by 2.5, give water by 2.5, it's a red flag for language. If the child is not using a 3-word sentence, I want water, by 3 years, it's a red flag. If the child's conversation is not clear by 4 years, or a child who has lost language at any age, is a red flag for language. Now let's look at social skills. If the child is not smiling at the parent by 3 months, if the child is not responding to his name by 9 months, if the child is not engaging in functional play, like you give him the phone and he'll put it to his ear and try to say hello, if he's not doing that by 2 years, if the child is not engaging in pretend play, multi-scheme play where he takes a pen and imitates and makes a car out of it, if the child is not participating in group activities, 3.5, like case number one, that's a red flag for social skills. Now let's look at sensory issues. Some of the children with attention issues and a lot of children on the autism spectrum may have sensory issues. So touch, they may either be hypersensitive or hypo. So a child might resist the nail cut, haircut. One who is hypo would be messy and he'd engage in self-injurious behaviors. Vestibular is spinning. So a child who seeks it would keep on spinning and would enjoy the merry-go-round. Proprioceptive is where the child is on the move all the time, jumping and engaging in deep pressure activities. Visual. A child who seeks vision would stare at bright lights, watch objects which are spinning. Hypersensitivity to sound could be a child for whom a normal sound would be too alarming and he'd cover his ears. And taste, like case number one, who had issues with textures of food. So these are some red flags for parents to be aware of certain sensory issues. Now let's look at red flags for ADHD. So if you have a little baby, what are red flags for attention? A child who has feeding difficulties, where weaning is an issue, where the child has sensory issues, doesn't like being cuddled. If you keep the baby down, he's fine. If you try to play with a toy, he doesn't sustain it that much. In the early childhood, a child who runs around, who engages in tantrums and has language issues, like case number one, a red flag for ADHD. Middle childhood, a child who has difficulties with friends and work, case number two. And adolescent age, of course, maintaining relations, academic issues, and risk taking behavior. So when we do an evaluation, what do? One, we do a clinical interview with the parents. And as I said, we rule out the differential diagnosis that all came up in our mind, and we assess the impact that it had on the family and other settings. Now, we are assessing development, we are assessing behavior. We are also, as Diptiman sir rightly said, a child who's not slept may have attention issues. So we are looking at sleep difficulties. The diagnosis that we do is done on the basis of something which is called as the DSM-5 criteria. Younger child, look for developmental and language difficulties. Older child, look for emotional or behavior conditions that could be comorbid. Now, these are the DSM-5 criteria. We are not going to go too much into this, but case number two, not listening to instructions, no follow through, difficulty organizing, losing things, forgetful. Hyperactivity, case number one, can't sit in one place, running around, climbing excessively, on the go, blurting out answers, interrupting others. Yeah. So these are the DSM-5 criteria, and these are to be assessed in the context of the child's development. Now, this assessment is not just based on what we see, it's also based on the feedback that parents give and the teachers or the counselors give it to us. So, if you have 6 or more symptoms in children less than 17 and 5 or more in children above 17, they are taken to be significant. Important to remember, attention issues generally always manifest before 12 years. The problem should be there for at least 6 months. It should hamper the child's functioning in at least two settings, and it should have an impairment in his social abilities, academic abilities, or ability to perform a task like a job. Rule out alternative diagnosis before you give a diagnosis of ADHD. So we obtain information from the parents, from the teacher, from the school personnel. Now, in an older child, a child who is in secondary grade, there are multiple subject teachers. So if we can get input from one or two teachers who have known the child for more than 6 months, or maybe, and also from maybe a physical sport teacher, that is ideal. In a preschooler, sometimes getting information from another setting is difficult, more so now in COVID, where kids are not going to school. And in a preschooler, if there are attention issues that we have picked up in one setting, we don't have to wait for a diagnosis in more than one setting to start working on our behavior strategies. Now, this is about the DSM-5 criteria. A child with autism can also be said to have hyperactivity. Now, a lot of parents must be aware that when we go in for an evaluation with the doctor gives us some checklists to fill up. There are some checklists which the parents fill up, and there is another one that is sent across to the teacher in school. Now, these are the commonest ones used: the Connors parent and teacher rating scale. There is this Vanderbilt scale. Now, these scales assess the child's attention, hyperactivity, or impulsivity, but they are not just looked at as the diagnostic criteria. They're just meant to complement what the doctor is seeing, and help the doctor get a picture of how the child is in another setting. It's also important to remember that these scales don't describe developmental appropriateness. So, if you have a 5-year-old child who has delay and whose skills are around 2 years, obviously his attention to task is going to be an issue. So, we need to see these scales as part of the big picture. Now, this is how a scale looks like, where you have the first 9 points, which are on inattention that we talked about. The next ones are on hyperactivity and impulsivity. The next ones are on difficult behaviors, which we call as oppositional defiance or conduct disorder difficulties. The next ones are on anxiety. Now, here, if you see the scores, there's 0, 1, 2, 3. So, if the child is scoring 2 or above, that's an area of concern for the parent or for the teacher. And then when we assess, we sort of get put all the pieces of the puzzle together. Academic performance is to assess how much of an impact that attention issue has on the child's performance. Now, getting feedback from the school is vital to help us understand how this child performs, to understand how this child's attention has an impact on his social behavior and on his learning. Now, sometimes we do order certain tests for children. An IQ test is not necessary for a diagnosis of ADHD. But as I said, if you have a child who's 5, but whose developmental age is at a lower age, maybe at 2 years, you would need to do a developmental test, either an IQ or a DQ. In a child like case number 2, where you think the child is intellectually quite capable but has specific difficulty in reading or spelling, which is a learning difficulty, we might do what is called as a LD test, where you are going to assess the child's IQ as well as assess the child's reading, writing, and math ability. A hearing and vision test may also be ordered as per the clinical discretion. We also assess the child's growth. Sometimes attention issue can be part of a developmental problem, which we could call as a syndrome. So we'd also do a neurological check and look for soft neurological signs. Like our case number 1 used both his hands, so he has mixed laterality issues. Like case number 2, who was clumsy with her hands. So sometimes developmental coordination issues can also be a part of ADHD, and we should not miss out on those. So if we look at the child's developmental profile, we talked about all the domains of development, which are the main ones which are mostly involved. One is language, second is behavior, sensory issues. Cognition, it may vary from every child. So you can have a child who has delay and an attention issue, or you can have a child who is cognitively able and has an attention issue. Now, some associated problems that we talked about, academic difficulties are known in around 40 to 45% children with ADHD could have associated learning difficulties, social difficulties, making friends, being with the group. Sometimes children with ADHD could bully. On the other hand, sometimes they could be even bullied by other kids. Sleep difficulties. Some children could have, as I said, they might be clumsy with their hands, and some might have tics, which could be blinking of the eye or vocal tics. The profile of a child with learning difficulty, remember we said that these are children who are cognitively, intellectually able. They may have difficulties in fine motor, in speech, attention, learning, and behavior issues which are secondary to their learning problem. So a lot of anxiety creeps in because they think that I'm not as good as my partner sitting next to me, and that's when low self-esteem may crop in. Now, other conditions in ADHD which we need to rule out is a seizure disorder. Sometimes a child might have an absent seizure. He might be lost for a minute, and we might think that he's inattentive. The second thing is a gifted child. You have a super bright child sitting in first grade whose cognitive abilities are at third grade. He's going to finish his work early, and then he's going to engage in disturbing other children. So that's something we need to rule out. And the others, we all talked about vision, developmental coordination issues, anxiety, environmental stimulation. Sometimes children have medical problems, an asthma or a chronic illness, which prevents the child from going to school. So his routine is not set, and there is a time when the child could have attention issues. So, whenever the child comes in, what we do is a comprehensive evaluation. Look for the symptoms. Are they there? Are they there more than 6 months? Do they pervade the child's life? And does it have an impact on his functioning? Look for coexisting disorders and rule out other differentials before you arrive at a diagnosis. Coming to preschool age, yes, we are picking up children with attention issues far earlier nowadays, and that is because kids are going to school at 2, 2.5, and there is a lot of expectation for our child to sit and comply to rules, and a lot of parental pressure also that our child is meant to perform. So we are more aware, and that is how we are picking up kids early. Now, there were studies done on children less than 30 months where they were made to play and videos were played back to see. And a child who changes activity frequently, doesn't sustaining in finishing the task or play that he's doing, a child who doesn't follow through on the instructions given, and a child who gets distracted easily are red flags. But these are not, this does not mean your child has ADHD. This is just something that we would want to work on with correct structure and handling. So important to remember, when do we refer a child with an attention issue? One, if the behavior is there for 6 months. Two, if it is there in more than two settings. Three, if it occurs during independent tasks as well as group activities. Four, if it cannot be explained by other circumstances. If it is interfering with the child's learning, if it affects the ability of the child to make friends, if it's inappropriate despite clear, consistent age appropriate expectations, and when it appears out of the child's control. On the other hand, you will wait if it is a recent behavior. It happens only with a particular person at home and not with anyone else. School, the child is fine. When he goes down to play, it's fine. This is something where we need to modify the handling at home. We'd wait if it happens only during group times where prolonged sitting is required. So this is something we could work on. Sometimes a child might get anxious with an event that has recently appeared and hence might appear to be inattentive. We can wait if the child has good friendship. If the behavior of the child changes with the person, then it's something that we would need to work on by modification. And if the child is engaging in only attention seeking behavior, this is something that we could wait. So important to remember, when do we refer, when do we wait? And appropriately occurring behavior that occurs inappropriately more frequently than the behavior occurs in most people and occurs to the point that it causes significant dysfunction. So a lot of times our children, we might feel are inattentive or they're hyperactive, and that's a phase of growth of the child. But if it is happening too often, if it is stressing me out, if it's stressing everybody out, if it's stressing the child out, if it's interfering with the child's academics and his learning and social skills, then it is a problem that we would need to evaluate. Also, it depends on the tolerance level of the parents and the teacher. So, if hyperactivity affects the ability of the teacher to cope, if the school needs to provide an individual shadow to be with the child, then it's a significant issue. If inattention is causing cognitive impairment, it's a significant issue. Now, I'm just going to briefly touch upon therapeutic strategies. One is behavior, second is medication, third is combination, fourth is therapies. Like, for example, a child has issues with his hand skills, a little bit of occupational therapy could help to better his skills. If a child has sensory issues, we could use sensory integration. If there are language issues whereby behaviors are manifesting, we could use speech therapy. A child who has a specific learning difficulty can be benefited with remediation. A child who has difficulty in social play or group play may benefit from a social skills group. Now, behavior therapy is a recommended therapy. Now, generally for preschool age children, children less than 4, are kids where we don't use medication. Here, we help to modify the behavior at home. So the parent is taught strategies of behavior, as sir rightly said, positive parenting. Learn how to work on a negative behavior, how to ignore, how to distract, work on analyzing the behavior, work on antecedent for the next time, set targets and rewards. You do, you get. You don't do, you don't get. Set consistency in handling. And when these strategies are taught, the parents feel more empowered and feel more confident to handle the child's behavior. Now, these are all the strategies that are used, and they can be implemented in classroom as well as with peers. Now, school age children or adolescents, you along with behavior modification, we might also need medication. Now the need for medication is individualized. How much time a child needs medication is also individualized. Medication is not lifelong. As the parents learn correct strategies, as the child gets a favorable environment, and with self regulation, the need for medication may go down in a lot of children. Let's just touch upon the best diet for a child with attention issues, specifically for today's age children, a diet which is low in sugar, a diet high in omega-3 and omega-6 definitely helps in attention because these are needed by the brain. They are antioxidants and anti-inflammatory, and studies of omega-3 supplementation have helped to reduce the need for medication, but they are not drugs to treat ADHD. Having a diet which has high protein in the morning, a diet which is low in artificial ingredients, coloring, preservatives is a good diet. However, they are not yet recommended in the standard guidelines that are given for doctors, but modifying a diet definitely may be a help to whatever else we are doing to help our child. So I'd like to end by summarizing that we need, as doctors, if we take a careful history, we might be able to pick up red flags in domains of development early. We need to rule out other conditions which could mimic an attention issue. If there is an attention issue, we need to confirm that the symptoms are there, they are persisting, and they are pervasive. Look for other comorbid difficulties that the child could have. Attention issues need to be confirmed in more than one setting, and the earlier we identify, the better our child does. I'd like to end by a quote which says, kids with ADHD need someone in their corner. Even if you don't always have the answers, be that someone. Thank you.
We have received a lot of questions.
Right.
Uh, it is so evident that the children in today's time are definitely going through a challenging living with the within the complexity of not going out, less of socializing, and different context, different question has come. So we may start taking the questions now.
Sure, sir. Sure.
The first question is, I hope this question is pertaining to the child who are hyperactive in nature. Do they have a problem in socializing? And with this, the question is also added,
Uh,
do they have a low IQ? This is a question, and is it true?
Okay. Now, as I mentioned in my PPT, children with attention issues can have normal intelligence, can have superior intelligence, or they could have developmental delay. So, ADHD is not an intellectual disability. You can have a child who's intellectually good but could have an attention issue. Two, does attention issue interfere with the child's socialization? Sometimes it does because this child is impulsive and doesn't think before he acts. Sometimes he might have a difficulty playing in a group situation where children are unconsciously all the time socially adjusting. So, yes, it could happen, but it's not the rule of the thumb. It's not that all children have this issue.
There is a parent who is writing, my daughter is 4 year old. Her talking is not yet clear. That means she is not yet verbal. Uh, Please advise.
Okay. Now, for every child is different. So ideally, every child needs a proper evaluation before we can answer this. But if your child at 4 years is able to communicate needs in terms of sentences, but just speech clarity is an issue, yes, that's something different. But if your child is having speech delay in terms of not indicating sentences for need, that's another issue. So every child would need a detailed evaluation to plan intervention.
So, out of curiosity, probably this question is coming whether ADHD can uh, be a part of ASD as well. Is it always?
Not always. Previously, autism spectrum and ADHD were considered as two different separate entities. Not anymore. Children on the autism spectrum primarily have difficulties in social skills, communication, sensory issues, and play. Hyperactivity is a part of their difficulty. In ADHD, hyperactivity is the main symptom, but these children love to be with others, love to watch other people's reactions. So the social component is preserved. That's how we differentiate both. But of course, you can have children on the autism spectrum who could also have hyperactivity.
So it is not very specific. Like that could be a typical child. They are hyper. That could be a lot of, or maybe a very thin line between how to read whether the child is hyperactive or maybe with ADHD or maybe some other associate disorder is there. So
Yes. Which is why we need an evaluation for every child so that you have an individual program for every child.
with this, Pratiksha ma'am is writing a 12-year boy with a symptom of ADHD, pretty impulsive, visit with hands, delayed with the milestone, and behind the peers in academics and emotional regulation difficulties. Does medication like few and helps in school time management. Does medication will help in the management of the child as well as maybe which are more within the timeline, like sometime they need to complete certain tasks within the timeline, and will medication have any kind of side effect? uh,
Now, an individual question for every child. If we have a 12-year-old who is having attention issues in terms of coping with academic work, you also mentioned that there was developmental delay. One, we need to assess where our child stands in terms of the class he is in, because if the studies are more difficult for me, obviously I could have an attention issue. Uh, Despite that, if there is associated ADHD, for this age, using a low dose medication, if you use it correctly, if you use it only need based, it may be beneficial. But as I said, every child is different, so a proper evaluation could guide as to the right medication and the right dose. Medications, if they are used judiciously, have less side effects. However, we need to remember that medication is not lifelong. A lot of kids, 40 to 50% of children, outgrow the need for medication.
With
But
this,
correct,
ma'am,
yes,
yes, ma'am. I may also contribute out here. When
yes,
a general question comes about medication, so there are we need to as a common parent we need to understand nutrition supplement cannot be called always as a medication because you are not treating something, you are
correct.
supplementing for as a food or a something which the child is missing out. So maybe this will help the other parents to put up their next questions. So as you said, very important, the safety part of any supplement or any food we eat. As we go and eat, we always look for go to a place to eat a good quality food, right? So same thing happens in the choice of nutrition as well.
Absolutely.
Uh, Now, from your experience, can you comment on the most frequently visited root cause of
Of ADHD?
of
Okay.
ADHD, or I see children skipping. I mean, milestone. She's also referring to. I see children skipping, crawling, fails to, and ultimately get into ASD or ADHD often. And the number of
Okay.
ADHD is increasing. The percentage is a lot of evidence, which
Right.
is increasing.
Right. See, like all developmental disorders, the incidence of ADHD has gone up dramatically in the last 2 decades. Now, pinpointing the exact cause in a child is really difficult. Sometimes, if there is a family history, the genetic component does have a role to play, but you can't identify a gene specifically in most kids. The second thing is sometimes children could have medical conditions which contribute to ADHD. Some syndromes, like a child with Down syndrome or a child with Prader-Willi, these are children who are likely to have attention issues. Sometimes medical conditions like thyroid can also contribute to attention issues. Sometimes diet has not yet been implicated, but there's a lot of talk about preservatives in food, pollution, and lots of factors that are being talked about. Um, Also, the environmental handling, the structures that we are able to see set for our kids. Previously, kids used to play outside and have a lot of open space. Nowadays, kids are restricted at homes, have gadgets in their house, and which is hampering the child's ability to play. It's not the cause, but it could be a contributing factor. So pinpointing a cause may not be feasible for every child and may not even be necessary to do. You don't need to do an MRI to find out the structuring of the brain in all kids.
Ma'am, with this, let's say the child who are hyperactive or maybe ADHD, you would be able to see that child at an early age.
Yes,
What is that age when we should be more careful, whether it is 2 year or 3 year, because
right,
the child is still growing. And the
right.
question is there any anatomical abnormalities may happen with the brain responding in this manner?
Okay, as I said, the earlier we work, the better it is. But it doesn't mean that if you have a 2.5-year-old who's not sitting down for a task occasionally, but most other times he complies, his language is good, you won't worry. Like those slides that I said, when to refer, when to wait, they're really important for parents to figure out when it's a concern and when it's not. Uh, Ideally, attention issues are generally picked up by grandparents at home, because they sort of look at the child from another angle. A lot of times, because children are going to school earlier, we have kids being picked up in play schools where there is the attention issue or the social difficulty starts manifesting. However, with better awareness, parents are coming up earlier. There is no finite age of 2 years or 3 years. Anytime you think attention is interfering with development, learning, and behavior, is a time to maybe just seek some advice on the child's development.
Thanks, ma'am. So, Dr. Patil is putting up this question. My 6 year son watches screen, either TV or mobile, a lot, entire day almost. As we are out for work, he has lost attention in studying and totally is fearful or avoids to sit and read and write. So, how should we make this or this attention need to back on the academic or study
Right.
beyond screen time? I think this is the biggest question of today. uh,
True.
Everybody want to give attention in different other than screen, but
True.
unfortunately kids are having a lot of screen time because of the school and pandemic reason behind
True.
it.
The pandemic has probably worsened it. Um, there is a lot of easy access for children on the gadgets. Also, it's very gratifying, meaning the amount of excitement and gratification that a 6-year-old gets by playing that game is not the same that he would get on maybe an academic task which demands more attention. But the first thing we need to do is to structure the child's routine, limit the gadget use. We don't want gadgets more than 1 hour a day. Now, in the pandemic, 1 hour a day is becoming difficult difficult, but it could be maybe 1.5 hours. Have a lot of physical activity for a child. It is hard for both working parents when you're back, you're tired, but we need to spend some quality time in terms of interaction. Sit down and play the games, physical games with them that they really like. Automatically, if this child is going to get to do a go for cycling with daddy, he is obviously going to not need the television. So initially it gets hard to set a routine, but once it falls in place, a lot of pieces fall together.
Thank you, ma'am. I think around 10 to 12 question. The question is same. How to increase attention?
Okay, now a golden question, really difficult to answer. As I said, um keep a structured routine for your child. If your child has a routine, when there is a change, your child will be able to comply to it. So especially during the pandemic, have for the child a routine activity time, self skill time. Get up, brush, get ready before school starts, have your bath, be ready, then there is school time. After that you have a 1 hour time where the child can play at home. Then maybe comes your nap time. Then you have chore time where the child helps you out at home. We can do joint activities together. There's all the more scope to praise the child when he does that. Then we can have your study time, which you can schedule. Have some physical activities, study in breaks, evening time, hour and a half to play outside. Come back, have a group time, group meal activity. So set a structure, set consistent methods of handling. We don't need fancy toys to improve our child's attention. We definitely don't need gadgets to improve our child's attention, but simple games where we sit, we wait, we learn to play, we learn role modeling with our parents, we learn sharing and losing. These are enough to improve attention in most neurotypical children.
Thanks, ma'am. There are a few questions related to the milestone they are doing, but not as expected. Say, for example, a 13-year-old is able to speak, but certain when the child is trying to speak, it takes time. Uh, Sometime with the language issue, finding word, juggling with the words.
Right. Right. Now, every child individualized, need to see every child before we can comment on this. Sometimes children have difficulty with expressive language, as in getting the words right. And a lot of times, children with learning difficulties could have such difficulty.
And at times the child I'm sure it happens if they are not able to convey certain thing, they also get irritated, they also get angry out of
True,
that.
true. So that's when the behavior manifests. So the earlier we pick it up, the earlier we work on it. There is speech therapy available, which is very useful for younger kids. It helps in improving speech clarity. A lot of strategies available to also improve expressive language.
So ma'am, how you will differentiate whether will it be a part of a learning disorder, or this is going to be a more like a behavioral work need to be done, because every child is different. And
Which is which is why when the child comes into us, we have a detailed evaluation. We are assessing the child's development, we are assessing the child's behavior, we are seeing the social skills of the child with his parents, we are getting feedback from the teachers. Teachers are our eyes to the child in school. So when we get information from all inputs, put it together medically, we arrive at the right diagnosis, so that we know the diagnosis is not important. We need to have a plan of action to identify the child's strengths and work on the child's weaknesses.
another question, we have been talking about children, what about to the adult who get ADHD?
Okay. Now, adult with ADHD obviously goes beyond my scope because I see children till 15. But of course, 40% of children who have attention issues when they are children continue to persist to have these attention issues in adulthood. It is not the overt hyperactivity that we saw in our case number one, but it is difficulty in tasks needing sustained attention. These are people who flicked from tasks. There is failure to follow through on instructions, difficulty with maintaining relationships or maintaining their job. And other difficulties that they could have. Unemployment also comes unfortunately as a part of it. So if there is, as I said, most attention issues are identified less than 12. So the more vigilant we are, the earlier we pick up, the earlier the adolescent is aware, we can teach him self-regulation strategies. Of course, medication also helps.
Thanks, ma'am. There is a specific question. My kid is autistic and hyperlexic. He pays a lot of attention to anything involving alphabets and
Yes.
number. He can sit for a long time, but if it is an activity like playing with the ball or with another child, he has no attention. That means the child is more specific to some kind of act which he loves.
Right.
Does this also indicate a part of ADHD?
Okay. Now, in children who are on the autism spectrum, as you mentioned, your child has hyperlexia. Hyperlexia is where your child is reading beyond his age. A lot of children on the autism spectrum love patterns, and when letters come together, they form patterns and they love it. So, when it is my favorite task, I can sit for hours all together. But in real life, I also need to go to school. I also need to interact with others. At home, I also need to do activities in a group, and their attention could be an issue. So, assess the child's attention in more than one setting. Assess the child's attention in tasks that someone else wants him to do. Um, I'm not sure whether we would say that this child has hyperactivity, but our attention issues are more related to our diagnosis of autism. So, yes, this child would need a detailed evaluation to assess the attention issue.
Now, ma'am, as we are reading the probably the bitter truth is the pandemic is not affecting as much as the ADHD or the even autism spectrum is doing, having more than 2% of the newborn population is getting into that as a global analysis, if we follow the recent data. Now, when we are saying this, how alert a parent should be when it comes to ADHD, and is ADHD completely manageable? I'm using the word manageable instead of not using the word treatable because this is a
Right.
disorder.
Right. Now, as I said, the attention issue is a subjective issue. Over a period of time, with correct structure, correct handling, correct parent strategies, correct environment in school, which is favorable for the child, a correct supervised environment for play, a lot of our children really do well in mainstream classes as well. Need for medication is individual. Some children may continue to need it, some may outgrow it. So definitely, as you said, manageable. Oh, for sure, definitely we can help our child achieve his optimal functional outcome if we set things right. The earlier we do it, the earlier our child is going to we capitalize on his strengths.
There is a question from Mr. Asraf. A 10-year-old girl having attention disorder, mostly on academic, very social, but she is normally ignored while playing with her friends because she probably struggle with the motor skills and associated with sports, and she is left-handed. Any suggestion how to manage or how to increase that social skill of the child?
Okay. Now, you've said that there are some attention issues more so when she is in a group. Now, if she is not good at sport, probably finding an activity which she is good at, which is her strength. If she is good at drawing, you can call her friends home. They can have a group activity together. If she's good at another task, maybe it might be storytelling, whatever. Find an area of strength, then plan a social activity. The child is more likely to enjoy it and want to do it more often.
Another beautiful question. My child is about 8 years old, diagnosed as ADHD, extremely intelligent. Can I dream a great career for him?
Pardon? Can I
Can
dream
I
of a great
dream?
career?
Yes.
Um, yes, you can. If your child is bright and your child has some attention issues, if we work the right way, if we identify the child's strengths, if we channelize his intelligence, this child, as I said, is really going to do well in the mainstream. We, however, need to be aware of his strengths, also be aware of the weaknesses, and use our strengths to overcome them.
There is a pretty emotional question coming. Do the separation from grandparents increase hyperactivity or ADHD? And does it also lead towards autism? Now, I believe the question, or maybe people wanted to have more clarity. Uh, does if someone a typical child is having ADHD, whether it will lead them towards ASD or ASD is ADHD? So, a lot of
Mm.
doubt
Okay.
they need to, yeah.
The diagnosis of ADHD and ASD mostly is as separate entities. Sometimes you can have autism with hyperactivity, but a child whose social skills are good and has attention issues is more likely to be ADHD. The handling at home, if all of us have consistent structured handling where we set our child responsibilities which he is capable of, a lot of times correct handling brings out optimum behaviors in child. Every child, every family unit works differently, so we are unsure as to who has a positive impact or not. We need to assess every family's interaction with each other, but a general strategy would be consistent in the way all of you handle the child's behavior at home.
Ma'am, Uma ma'am is asking if the child is having an extremely high IQ. And again, I have to assume because it's an incomplete question, and if the child is hyperactive,
Mm.
is
As I
there
said,
worrisome thing?
um, not worrisome, but yes, we need to work on it, because channelizing his child's intelligence into activities that he or she likes is really vital to keep the child, help him achieve his strengths better.
Okay, thanks, ma'am. There are um, some question on the Facebook section. We are also live on Facebook. So my daughter is 6 years old. She need a constant pampering to do routine walks like brushing, bathing, or to do homework. Uh, are there the symptoms or the case of ADHD?
Okay, a lot of us Indian mothers, we love to do things for our kids, not realizing that most of the things they can do. So, if your child is 6 years and can brush and can eat by herself, don't keep telling her all the time. If you set a structure, if you set a routine wherein the child does the task by himself, I'm sure she'll do it. Sometimes what we do is we keep the plate and we say, eat, eat, cow, cow, and when she doesn't, we'll end up feeding. So the child thinks, chalo, why to take the trouble? Let mama feed me. So if we work on this behavior pattern and break that cycle, I'm pretty sure a lot of our kids at 6 years can eat by themselves, can dress themselves, definitely can brush. So we just need to modify the way we work on their behavior.
And at times, the children who are still not able to handle themselves by self, like the toilet manners and all, uh, I could understand from your views they require a complete evaluation,
Yes,
and because every child is different, and
true.
what exactly, because there are we have attendees from different part of India and few from outside India as well. They wanted to know, this ADHD, is it completely manageable, treatable, curable, or they should be only doing certain conscious effort, sometime doing some screening and then engaging the child with a special educator, or is there any specific attention to be given to increase their attention span also, because
Okay.
number is, I mean, different queries, different, but they want clarity.
Uh, as I said, we are not looking at a cure for ADHD. We are looking at what optimally we can do to help our child achieve his best outcome. So, setting a structure, setting positive handling strategies, having an environment in school which is friendly, having accommodations, creating opportunities for good, positive social interaction to boost the child's self esteem, and sometimes a little bit of help of medication goes a long way in helping our child do well.
Ma'am, you covered one point in your PPT also, the premature birth of the child. And let me add another question which has come. Are there chance of acquiring ADHD or ASD for, is it the chances are high if one of the twins are born through IVF?
That's a tough one. We don't have enough studies on children who've been born through IVF and whether they landed up having attention issues. But a lot of times, neonatal events, being born premature, or having neonatal events like there were low sugars or the baby didn't cry at birth, sometimes what that does is it may hamper the executive functioning of the brain. See, there are some tasks which are really complicated. Attention is a part of it. So maybe having these events may predispose some children to attention issues, but it's not hard and fast that every child who's born premature would have an ADHD.
Absolutely, ma'am. There are plenty of questions, ma'am, you could answer, and we will take maybe just another two question.
Yes,
Uh,
sir. Sure.
the question is: do kids with ADHD change profile as they grow up? Like a kid diagnosed with even ASD, when little is showing huge interest in people and the world around, but not appropriately, and has hyperactivity as well. Does
Okay.
that mean the profile is changing from ASD to ADHD?
That's a very good question and a very tough one to answer. Development is an ongoing process. It's an ongoing process for the child. So, a periodic evaluation when we do on the child. A lot of children who, when they are young, seem to have autistic features. As they grow older and having autistic features and language difficulties and attention issues, once the language comes in and correct intervention comes in, might seem to have more of a social communication difficulty and ADHD. So, however, 80% of children who may manifest as autistic features in a younger age, less than 4, may continue to keep the diagnosis. The profile may change in terms of strengths or weaknesses. But if we were to do a formal test on a child, if we've done it at age 4 and the child has been diagnosed as having autism, maybe on the ADOS, maybe at 12, he may still qualify for a diagnosis of autism. The severity may be lower. The severity may change, but probably the label in 80% kids does tend to stay the same.
Okay, ma'am. Dr. Patil is having a question for you. My 6-year son has got repulsive for studying as in doesn't want to read even storybook or write. He is exposed to screen almost all the day and wants it all the day. Is it ADHD? He does not sit at all at one place, doesn't pay attention to online classes.
Uh, Probably just now it is environmental because we need to put in a structure, we need to have activities other than the gadget times, have a change of environment, have a change in the way you handle your child. If the symptoms persist after 6 months, then probably we need to do an evaluation.
Absolutely, ma'am. And I think just before the session, we had a little interaction when this pandemic is going on. Many children, not many, most of the children are inside like their school or everything, they're taking it online. Simultaneously, it has affected a lot to the children who are into the spectrum, particularly uh, the kind of engagement the parents are having with the child. There is a mood swing. There are a lot of anxiety related challenges the child is going through.
True.
Anything? you wanted to convey to them?
Anxiety is very commonly seen in our children on the autism spectrum, especially during this pandemic. I'd say 85% children are manifesting it. It may not be by a behavior or a phobia. It might just manifest in their day-to-day activities. Our core symptoms of autism go up. Our sensory issues go up. So what I'd say is for parents, set a structured routine. Have a sensory diet in place. Keep physical activities which are practically feasible in place. Set your child a schedule where he knows what's going to happen when. Uh, um, Try to keep your anxiety level low, because the minute we show it, it reflects on our child. Also, because they love gadgets and they're easily exposed to them being at home, set a time when they get it. Use it as a reinforcer after we've done the time. And as I said, set a schedule which has chore time, which has shared activity time, and the gadget time to about an hour and a half.
You said very correctly, the physical activity which are doable within the constraint of the time. Uh, we as I'm the best mom, an initiative, we are extending to all the children absolutely as a complimentary. For now, it's going on for more than 4 months. So I would request all the attendees, if they have their child or they want to recommend any children, every day from 5 to 5:30, the links are already given out here. If they want to have, please join and let the children have a good time. This is a playway method yoga we are doing. And many questions have come related to emotion, the physical aspect, the like when we are talking to them, we all have to accept we have to give a lot of attention to emotion while not compromising the other aspect of our life. So, Dr. Archana Kadam is with her clinical and as a social initiative, she keeps on interacting with schools, thousands of children, and on a day-to-day basis. Even now, also, she's a frontline warrior. Like when you are going and seeing the children, but limited. Many parents. There is a question also came. How best they can reach out to you in this phase of life.
Right.
So they are asking time. Can they come and meet you at times
Sure,
for
sir.
your consultation?
You can give them my contact for sure. Yes.
So attendees, if you have any specific, the contact details are available with you. Please send us an email. We will try to get you connected with Dr. Archana Kadam. Ma'am, I'm extremely thankful. We have taken up around 50 questions, and all are for the goodness of the society. And we are absolutely lucky to have you today. And thank you so much for your wonderful input and your valuable time, ma'am.
Thank you so much, sir. It was really a pleasure to be part of this. Thank you.
Thank you so much. So, our attendees, we are going to continue this initiative of ours, and the next on the domain, we are having another session which is coming up 31st of October, hyperactivity, when to treat and when not to treat. Very obvious questions from many parents. So let us address as much we can under this platform. So once again, thank you so much, all of you, and have a good night.
Thank you, sir. Good night.
Thank you, ma'am. Thank you.